Well, hello and welcome to this wonderful How I Practice program entitled Selecting and Optimizing Quadruplet Therapy in Newly Diagnosed Multiple Myeloma, also known as 4 is More. My name is Dr. Joseph Mikhael. I'm a professor at City of Hope and have also the privilege of serving as the Chief Medical Officer of the International Myeloma Foundation. Joining me today is an absolutely wonderful, not only friend, but colleague, Dr. Krina Patel. She serves as head of the myeloma program at MD Anderson, is an associate professor there. Krina, it is so good to see you.
Thank you so much for having me. Always a pleasure to work with you.
So before we dive into this 4 is More concept, just a few key housekeeping notes as we go through here. Our faculty disclosures are as you see them on the screen. Prior to the program, we sent you a pre-survey. You had a pre-survey to fill out. If you haven't had a chance to do those polling questions, please quickly do it now through the QR code that is available to you, and make sure that you complete your evaluation at the end, and I'll remind you of that at the end so that you can get your CME credits. Just a few other comments that this activity is jointly provided by Global Education Group and bonumce. The program is supported by an independent educational grant from Janssen. And be sure to watch our handles for the coming weeks for the additional multiple myeloma CE programming, and the follow at bonumce for more CME certified programs on X or Twitter. And lastly, before we start thinking about how we treat frontline therapy, let's quickly review our learning objectives to make sure we are charting the right course together. So upon completion of the educational program, you should be able to do 3 things. 1, appraise the efficacy data from pivotal clinical trials assessing current and emerging quadruplet therapies. It is remarkable how many trials there are that Dr. Patel and I will quickly overview with you. Secondly, to define patient-specific factors impacting quadruplet therapy selection for patients with newly diagnosed multiple myeloma. It is not a cookie cutter in myeloma. We make very specified decisions based on various factors, and we'll talk through what those factors are so you can use them in clinic. And then lastly, interpret the role of MRD, or minimal residual disease, in guiding decision-making for patients with newly diagnosed multiple myeloma. We are slowly reaching the state where MRD is not only a prognostic tool, but becoming indeed a therapeutic tool or decision-making tool in our therapy. So with that, I'm going to ask you, Krina, to give us, I know there are a lot of words on this slide, and there's a lot that influences our selection, but multiple myeloma is complicated and people are complicated. So tell us a little bit about when you start to think about that initial treatment, what are the factors in your mind that influence which treatment option you're going to choose one over another?
Yeah, no, this is the fun part, right? This is the part where to get the best outcomes, we really need to see that patient that's in front of us. And therapy really isn't one size fits all. We have the NCCN guidelines. We're going to talk about all these trials, but the more options we have, the better tailored we can make it for our patients to make sure both efficacy and toxicity are optimized. So patient-related factors really includes things like frailty or performance status, especially for older patients, comorbidities. Again, a lot of our patients will have other issues that cause renal failure, and then the myeloma can too. And another big one that sometimes we don't think about, but access to care and transplant eligibility. All those things really change what your next line of therapy or your first line of therapy is going to be to, again, give that longest PFS with the best quality of life. And again, I think that some of the things like intensive regimens, like auto transplants, we can get our oldest patients through, but maybe with our newer treatments that we're going to talk about with our quads, do we really need to push everybody through an auto transplant where there's a little bit more mortality and morbidity? But then not just the patient, really the disease is also important. So the stage of the myeloma, how much tumor burden is there? What is the bone marrow involvement? Do people have high risk cytogenetics or FISH, which maybe we do want to be a little bit more aggressive? Risk benefit changes based on that. And then MRD, as we're going to talk about again, can we use MRD to stop or increase therapy based on how that patient's results have been with that initial induction and newly diagnosed treatment? So again, patient therapy has to be tailored for both patient factors as well as for disease biology.
It's beautifully said, Krina. You know what I actually particularly like of the way you presented that is that you started with the patient factors, right? Not only do we always have to remember we don't treat myeloma, we treat people, but that really is an important factor. And I think for so long historically in myeloma, we just put people in two simple buckets: are you transplant eligible? Or you're not transplant eligible. And I think those days are changing. I think as we think about quad eligibility, as we think about how we can manipulate these quads to the benefit of patients, I think it's really great that we start with patient-related factors and then, of course, disease-related factors as well. Well, let's get really practical. Let me throw out a case. Here is what I would argue is actually a pretty common case. A 64-year-old white male presents with back pain and fatigue with some normocytic anemia, the hemoglobin at 10.5, marginally elevated creatinine at 1.3. He's a little bit hypercalcemic as well, a little over 10 at 10.2. His LDH is up. And the PET scan sadly demonstrates multiple lytic lesions. The patient is only in ISS stage 1. We didn't go into all the details of the marrow and the cytogenetics, but he has no risk cytogenetics, even with our new definition of high-risk myeloma. And he's quite fit despite the back pain and the fatigue, and he is deemed eligible for transplant. So based on the guidelines that we have, the evidence that you're going to share with us in a few minutes, Krina, we've got options here. We could give him a triplet with VRD or bortezomib, lenalidomide, dex. We could give him the quadruplet, adding daratumumab to VRD. We could just give him a doublet of lendex, or we could give him isatuximab in combination with VRD. What are your sort of initial thoughts as you think about this gentleman, putting it into the rubric you just shared with us about factors influencing therapy?
Yeah, no, I think this is great, right? It used to be VRD and everybody got it. And now we have options. I think for this patient, quadruplet makes sense. Again, he doesn't have major comorbidities that I'm worried about in terms of toxicity. He has standard risk disease. Sometimes we think, oh, well, maybe we should do less for our standard risk patients, but that's really not the case. Our standard risk patients do even better for longer when they get the full treatment that we know works the best for even our high risk. At least so far, that's what we've seen. So here, I would probably pick B, DVRD for 4 to 6 cycles, and then he is transplant eligible. So again, as of today, autologous transplant is still very much real and provides the best long-term PFS. And we'll talk about the PERSEUS study. It shows much better than VRD, and I think I'm not worried about the side effects. I will say, the bortezomib we can talk about later in terms of twice weekly versus weekly and the neuropathy. I monitor that because I don't want my standard risk patients to have really bad long-term side effects, but I would still use all 4 drugs. I don't know if you would do anything different for high-risk patients.
No, I think I would have the same sort of thinking. I mean, as I say, I know you're about to educate me about the quadruplets, but I've seen the slides before. But no, we know that there has been this tidal shift from triplets to quadruplets, and that one extra drug has actually made a big difference in getting people into remission and keeping them. What strikes me about this, as I know you're going to share with us shortly, is the relatively smaller number of patients now who actually don't respond to the quadruplet. That number is getting tiny, frankly. And so it's remarkable to me. So I would take the same approach. I think right now, we have DVRD sort of FDA approved. I think we could consider ISA VRD depending on the context because they're so similar. But let's hear from you. You tell us why both of us came to the same conclusion.
Perfect. All right. So going into the Perseus study design a little bit. So again, this is for transplant eligible, newly diagnosed multiple myeloma. And we recently saw results from several trials that highlighted the benefit of adding anti-CD38 monoclonal antibodies. And again, as you said, daratumumab and isatuximab, we'll talk about both of those, to the standard regimen of bortezomib, lenalidomide, and dex, which of course we call VRD. So coming to Perseus, this was an open label phase 3 trial that looked at DARA VRD versus VRD alone, and again, transplant eligible patients. There were 709 patients that received upfront VRD with or without DARA, and then they did get transplant. Then they got 2 cycles of consolidation with DARA VRD or VRD, depending on which arm they were randomized to. And those who got VRD got LEN as single agent maintenance versus those who were in the DARA VRD arm, the quad arm, received DARA LEN for maintenance. And those who are on the DARA VRD arm, we actually bring some MRD into this. If they're MRD negative after 24 months, they continued on single agent LEN maintenance after that. If they're MRD positive, they continue with both. And so the results, Again, just pretty impressive overall response rates, but addition of DARA, of sub-Q DARA to standard VRD basically significantly improved 48-month PFS of 84.3% versus 67.7%. And again, this is the 48-month PFS. So like you said, most patients actually respond to this and we bring that PFS curve a lot higher compared to the triplet. And then looking at the secondary endpoints, again, MRD undetectability, 75 versus 47.5% at 10 to the minus fifth. So the quads, you get much deeper responses, which we think leads to that better PFS. And sustained MRD, which is really the most important part of greater than 12 months or greater than a year, 64.8% versus 29.7%, so more than doubled. And again, the 4-year PFS rate with the quad translated to a 58% reduction in the likelihood of disease progression with a hazard ratio of 0.42. So pretty impressive just by adding one extra drug. These patients do really, really well. And again, not shown on the slide, it's really important to note that the benefit with DARA VRD was consistent across subgroups, including those with high-risk cytogenetics, disease stage, and performance status. So it's tolerable. And again, in high-risk patients. And so really, based on these results of the PERSEUS study, for us, daratumumab plus VRD is considered the standard of care for all our newly diagnosed patients who are transplant eligible. And so with that, then we come to our other anti-CD38, isatuximab. So the GMMG HD7 trial is an open-label phase 3 study that now looks at isatuximab plus VRD versus VRD alone. And these are also transplant eligible newly diagnosed patients. This is about 662 patients that either got VRD with or without isatuximab, followed by the auto. After the induction therapy, followed by the transplant, then patients were actually randomized to ISA lenalidomide versus lenalidomide for 3 years until progression of disease. So a little bit different than the MRD. They basically had a time point of when they would continue the doublet. The addition of isatuximab to standard VRD, again, adding that anti-CD38 significantly improved the PFS, as well as the MRD negativity rates and the complete response rates. And again, PFS has not been reached in either arm at 48 months since the first randomized assignment, but PFS benefit with ISA-VRD is seen regardless of the maintenance therapy. So the hazard ratio, again, 0.7. The separation of the curves is similar to the Kaplan-Meier curves we saw in PERSEUS as well. So again, pretty similar in terms of the quad beats the triplet, looks really good. And secondary endpoints show the same. The MRD negativity rate following transplant for those who got the quad is much better than VRD at 66.2% versus 47.7%. And then patients in the ISA-VRD arm achieved a complete response, more so compared to those who got the triplet. So again, deeper responses with both CR and MRD rates. And then updated results in 2024 just show that that MRD rate continues to deepen following that transplant. So we know over time that tells us a lot more about MRD and that PFS is prolonged with the quad versus the VRD. So Joe, that was a lot of data. Do you think based on what we just discussed that we made the right choice for our patient that we had talked about?
Well, I'm not into patting myself on the back, but I do think we made the right choice. Obviously, the talk is called for is more, but joking aside, like it is really remarkable when patients get that deeper response, how much more durable it is. We saw that in both approaches, both strategies. I like that we have different strategies, right? Especially when it comes to the maintenance side of it, or that we have 2 different monoclonal antibodies that we can use. But I was quite convinced that there's no doubt adding that 4th drug really helps in the context of transplant for patients who are eligible.
Oh, perfect. I agree. I think we pick the right choices. And again, I'm just excited we have more than one choice for our patients. But for this patient, I agree. Of course, in myeloma, a lot of our patients are older, and then some patients maybe aren't transplant eligible. And so our second case is a 74-year-old African-American woman with newly diagnosed myeloma. She has ISS2, stage 2 disease, but still standard risk cytogenetics, moderate frailty, and she's deemed transplant ineligible due to comorbidities. So following 6 cycles of DVRD, she achieves a CR, and her bone marrow that was done actually is MRD undetectable at 10 to the minus fifth. So what is the most appropriate next step in the management of her myeloma? So Joe, based on these results, these answer choices, what would you do for this specific patient?
Yeah, this is a great question. It starts by me saying I'm thankful that the patient was given a quadruplet, whether it was ISA VRD or DARA VRD. I think that was the right choice. And obviously it worked. Look at that depth of response at 6 months. And so even though some of the protocols might give bortezomib for longer, I like the idea here of just continuing the daratumumab and the lenalidomide from the choices you gave me in A, because I think we learned even from the earlier Maya study that when patients continue the immunomodulatory drug and the monoclonal antibody together, which by the way tends to be very easy on the patient because we can give low dose lenalidomide and by then they're getting the DARA once monthly, can maintain their quality of life, but also really keep them in remission for a long time. And to me, I think the data is strongest for doing that.
Yeah, no, I completely agree. I think, again, these are the patients we worry about their comorbidities. So as long as they're not having major, infections or other things where we might have to hold, but continuing that maintenance, especially for those who don't get transplant, I think does improve that PFS much better.
Absolutely. So let's dive a little bit into the data that supports hopefully what I just tried to make a case of, and really two large studies here. The first one was the IMROZ study, which actually led to the first quadruplet being approved in transplant ineligible patients. So these patients were given isatuximab, as Krina mentioned earlier, the other CD38 antibody we use regularly, added to VRD in patients who were deemed not eligible for transplant. I remember when this was being designed, people thought, can you actually give a quadruplet to a patient who is ineligible for transplant? And indeed, they were able to do it. And this was compared to the more standard approach of giving VRD, where, of course, there was a step down of not continuing the bortezomib, so step down to ISA-RD versus RD. And this was continued until patients progressed or had unacceptable toxicity. And it's remarkable. This is the key data here, the 5-year PFS. We see 63% of patients in the quadruplet arm still in remission, whereas only 45% with just the VRD. This to me was particularly convincing, even more so, not to do too much cross-trial comparison with Maya, where that number was not as high. So remarkable to see nearly 2/3 of patients still in remission. Remember, these are patients with the average age of approximately 72 to 73. And this, of course, is driven by a deeper response. So you see the differences here in MRD status between the two. Very similar approach with daratumumab VRD in the CEPHEUS study, that CEPHEUS interestingly looked at patients who were either transplant deferred or transplant ineligible. In this sub-analysis of the transplant ineligible patients, again given DVRD versus VRD, where the bortezomib is also dropped after those first 8 cycles, we see a similar design. And again, another dramatic difference, both in the depth of response, as you can see, over 20% improvement in MRD negativity, and also a very significant difference in the PFS here, now looking at 54 months of 68% versus just under 50% for the VRD alone. So again, we see both deep and durable responses in patients that receive the quad. Now, lastly, before I turn it back to you, Krina, one of the things that becomes challenging here is people say, well, can I really give that quad? I mean, is this really can be done in clinical practice? I mean, IMROZ, they did it up to patients to the age of 80, but sometimes we may be concerned about our sort of real world experience. And here, one of the things that really helps me in the clinic is that although the clinical trials obviously have to be done with a very meticulous protocol, we have some flexibility. In fact, there was a third trial we didn't get time to cover called the benefit study, where the bortezomib was actually just given once weekly. And I don't know what you do in your practice, Krina, but I almost always give bortezomib once weekly, transplant eligible or not. And similarly, the dosing of the immunomodulatory drug can be reduced. The dosing of the dexamethasone can be reduced. All of those things can really help. And even in the case that you shared with us, MRD status might allow us to back off a little bit earlier as well. So it may seem that 4 is more, and indeed it is, but more is a relative word. Sometimes it's just a little bit more, if you will, than the triplet, and sometimes it's a lot more. And I love having that flexibility, because as you started your discussion earlier, Krina, I love the idea of making sure that I can match the treatment to the patient, where I know this patient may be at greater risk of neuropathy, and so I want to give once weekly bortezomib and then stop it earlier, or this person is not reacting well to the steroids and I'll taper it more quickly, or this person has some cytopenias, I'll use a lower dose of lenalidomide. Does that strategy resonate with you? Is that what you do in your practice too, Krina?
100%. I agree. The idea of having that extra therapy, that four, is just to kill more myeloma cells because even our older patients with comorbidities deserve getting that depth of response because that's what leads to that PFS. So even if you have to decrease the dosing so they can tolerate it better, so they don't get the side effects, DVRD light, right, or ESA-VRD light, it makes sense, and patients really can tolerate it when you decrease those doses. And I do the exact same thing: the weekly bortezomib, the lower dose of steroids, maybe even stopping the steroids over time, and then the lower dose of the IMiDs as well. So you do have to watch these patients and follow up with them regularly, and maybe adjust dosing based on if they're having side effects or not. But I think our older patients deserve the same level of input that we put into our transplant eligible patients too, and they can do really, really well for a long time.
Oh, I completely agree. I have so many patients in my practice like this now, and it's great because they're in remission for a long period of time, and after you've gotten through that initial, induction phase, they can stay in for a long time. Well, let me turn it to you, Krina, to talk to us as we get towards the end here, believe it or not, about MRD, because this is in some ways not fully ready for prime time, but it is such a powerful tool, and we're sort of chomping on the bit to use it. Well, what are your thoughts about using MRD up front?
Yeah, so I think, it's really important that we think about this, and not all my patients want bone marrows all the time. And so right now, MRD really is in the bone marrow biopsy. I know there's a lot of tests out there in the peripheral blood, et cetera. We're not even close to prime time for those yet. But for now, whenever I do get a bone marrow for a patient, I think that MRD testing is really important to help me say, what is that status of that MRD at 10 to the minus fifth versus sixth? But really, if patients weren't tolerating their quads very well, can I decrease to a maintenance like thing where it's a doublet or a triplet for the drugs they can tolerate? Can we de-escalate for our patients that are, low risk? That's really where I use it right now in terms of maintenance. Should I give a doublet with, CD38 plus Len, or should I just do Len? I think it helps with both our transplant eligible and transplant ineligible patients, but it might help with adjusting the drug dose. If someone's having more side effects, I'm more likely, if they're MRD undetectable, to quickly go down on that IMiD, than say, hey, you need to go through this a little bit longer, just so we can make sure you have that, long-term PFS. Since we've done all this work, do we need to sacrifice a little bit more? And really, it comes down to, again, the dosing considerations for our patients. So, Joe, how do you use MRD for deciding in clinic, in terms of induction therapy or maintenance? Is there a specific time you like to do MRD, and how do you use it?
Yeah, I have to say, and maybe I tend to be a quick adopter, but I'm cautious here because I think there is a bit of a risk of over interpreting, primarily in two groups of patients: patients who have high risk myeloma, where MRD, ironically, may be more of a goal, but I'm nervous about de-escalating because of MRD, because I think we have a lot of studies that show that those patients do need a full court press to continue treatment. And then those patients with translocation 11-14, who paradoxically either may take longer to get into MRD negativity or may not get in and stay in as long, and yet still do well. That's the irony. So I always think of the two extremes of MRD, that in the highest risk and the lowest risk patients, it's not as reliable. But for the vast majority in the middle, I mean, I agree with you. I also pair it with any side effects a patient's having, right? I don't want patients to suffer with ongoing side effects if they don't need it. But I think if you and I were to do this program again in another year and in 2 years from now, we'll have even more answers to these MRD questions because there is so much to learn about MRD. Well, it's hard to believe that we are pretty much at the end of our program. So I'm just going to leave you with a few key takeaways as we wrap up. So quadruplet induction is really the name of the game now in patients who are transplant eligible, going to transplant. It's become now the standard of care as we use a monoclonal antibody, a proteasome inhibitor, an immunomodulatory drug with some steroids. And this is now proven not only in transplant eligible, but indeed in transplant ineligible patients. We have two different monoclonal antibodies that we can choose from: daratumumab or isatuximab. And when we choose those regimens, we choose them based on patient disease-related factors, and we can alter those dosing strategies to make sure that it is both tolerable for the patient and yet still efficacious against the multiple myeloma. And we do think that MRD is going to be a bigger part of what we do in the future, that not only does it demonstrate to us the efficacy of these wonderful quadruplet regimens, but also will allow us with time to make more decisions about de-escalating therapy over the long run. So I would like to thank, first of all, Dr. Krina Patel for joining me today. Krina, thank you always for joining me. It was great to chat with you today.
Always great to work with you again. This was fantastic.
And thank you for our audience for listening in. Please make sure to claim your CME credit by completing the post survey and evaluation form in the links below, or by following the QR code that you now have up on your screen. As we continue to move forward, please stay tuned also for our next activity as we continue to leverage social media to reach those of us who are caring for our patients with multiple myeloma. Again, thanks so much for your time today.